Hello guys and welcome to this video. So this video is a continuation to our discussion about diuretics. So we already talked about some renal physiology in the first video. In the second video we talked about diuretics, and in this video we are going to talk about thiazides. So thiazides are very common drugs in treating hypertension, and they are the mainstay in treating hypertension. And in this video we are going to talk about the pharmacokinetics of these drugs, the pharmacodynamics, the therapeutic uses, and the adverse effects. So let's start. So let's start by mentioning the types of the thiazides. So thiazides, we have in general two categories of the thiazides. We have the true thiazides and we have the thiazides like diuretics. So thiazides like. So the main difference in those is that they both have different chemical structure between the two thiazides and the thiazides like, but they both share the active sulfonamide group. Yeah, so they both have the active sulfonamide, which would have the effect of the thiazides. The most common true thiazides, we have the hydrochlorothiazide, which is the HCT, hydrochlorothiazide, and we have bendroflumethiazide, bendroflumethiazide. In the thiazide-like category, we have the chlorthalidone, that's a very common drug, chlorthalidone, and we have the indapamide, and we have the metolazone, so metolazone. Next, we will mention some pharmacokinetics that they are useful for us understanding those type of diuretics. So those have good absorption, and after they get absorbed, they go into different organs, including the kidneys. They would flow in the renal capillaries here beside the proximal convoluted tubule, where they are going to be secreted here. So they are going to be secreted from the proximal convoluted tubule. So into the nephron here, into the filtrate, and they will flow with the filtrate into the loop of Henle here until they reach the distal convoluted tubule here. And the distal convoluted tubule is splitted into two regions. So distal convoluted tubule, it has a proximal part, so proximal, and it have distal part, so distal. The thiazides work on the proximal, so they work here and here and here and here. Yeah, and they have a long half-life, so long half-life, and their action starts after 1 to 2 hours after taking these drugs. So action starts after 1 to 2 hours. This would differentiate them from the diuretics that would have a faster action. They would work, if the diuretics would work after 5 minutes if they are taken intravenously, and they would work after 30 minutes if they are taken orally. While those, most of them will be taken orally, these drugs, and they would work after 1 to 2 hours. So they would have a delayed effect compared to the diuretics, of course. Now let's talk about the mechanism of action of these agents. So again, we talked about how they reach the distal convoluted tubule here, the distal convoluted tubule, and we talked about how it is split into two regions, the proximal and the distal convoluted tubule, and they work on the proximal part. Here they inhibit the Nacl transporter. So we have Nacl here, transporter, and the thiazides would inhibit this transporter, so negative to this transporter, and we would lose 7% of sodium, so 7% Na, and we also would lose the same amount of water, so 7% water, because salt and water move together. We also lose the chloride, so chlor, and the sodium that is excreted here, because of blocking this, would move through here, and we have the aldosterone on the distal part. So aldosterone will work here on the distal part of the distal convoluted tubule, and the excess sodium that is excreted here would be absorbed by the aldosterone effect. So the aldosterone would try to compensate for the lost sodium, and it would absorb the sodium here. So some of the sodium would be absorbed, some of it, and with the water of course, but in expense of the potassium and the hydrogen. So we also would lose the potassium and the hydrogen, and that's by the aldosterone effect. So aldosterone. And we also would lose the magnesium, but that is an unexplained mechanism. Unexplained. So we lose 6 things. We lose the sodium, water, chloride, potassium, hydrogen, and magnesium. But the calcium is not actually lost here, and that is the main thing that differentiated from the low diuretics. The calcium is not lost, and it is the opposite of that. The calcium would be actually reabsorbed here and stimulate absorption kind of thing. So the calcium would be more absorbed, more even than the normal. And that would make the thiazides very useful in treating hypercalciuria, because they stimulate absorption of the calcium that is going into the filtrate. And that's a very important thing that differentiates the thiazides from the low diuretics. Because in the low diuretics, we would lose majority of calcium. Yeah. So that's one way the thiazides work. The other way is that they increase the prostaglandin E2 and prostaglandin I2, but not to the same degree as the low diuretics. So we would have increase in PGE2 and PGI2, and we would have vasodilatation, but that's not to the same degree as the low diuretics, because the low diuretics have better vasodilatation as a result of PGE2 and PGI2 increase. But the thiazides are different from the low diuretics in their ability of vasodilatation by a direct mechanism. So they would have direct vasodilatation in addition to the prostaglandin E2 and I2 mediated vasodilatation, and that would make them different from the low diuretics. The other point is that the thiazides would work until the GFR is as low as 40. So the thiazides work as GFR as low as the GFR low as 30 or 40. And that would make them also different from the low diuretics, because the low diuretics would be more efficient and they would work even if the GFR is 10. So those would be the thiazides would have would not work if the patient have renal failure and their GFR is less than 40. And the other thing is that if the patient is taking NSAIDs, non-steroids anti-inflammatory drugs, this would lead to the thiazides would not work. So this would inhibit the thiazides action. Because the NSAIDs would cause a renal vasoconstriction. So renal vasoconstriction, VC. And that would make the thiazides not work. Now let's talk about the therapeutic uses of these drugs. Now the first one is that the hypertension, that's what they are famous for. And they work to relieve hypertension by 4 mechanisms. First, they are reducing hypertension by volume reduction. So volume reduction as a result of blocking the NaCl. Because of the blocking of the NaCl cotransporter, that would make us lose 7% of water. The other mechanism is that increasing PGE2 and I2, PGE2, I2 would give us vasodilatation, so VD, that would reduce blood pressure. They also would give us vasodilatation by direct mechanism. And finally, they also would decrease Na, so they would decrease sodium in the blood because they would deblock the NaCl, so they would decrease the sodium in the blood, and then the sodium would make the blood vessels sensitive to the catecholamines, but if we decrease the sodium, this would make the blood vessels less sensitive to the catecholamines. So sensitivity of the vessels would decrease to catecholamines, and that would give us also vasodilatation. So that would give us the hypertension relief from these drugs. So volume reduction, vasodilatation because of the increase of the prostaglandin E2 and I2, and vasodilatation because of the direct mechanism, and decreasing sodium would give us vessels less sensitive to catecholamines, and also would give us vasodilatation. And the vasodilatation is the main mechanisms that the thiazides would relieve hypertension. So vasodilatation is the main mechanism by which they would relieve the hypertension. Now they also used in heart failure because they would decrease volume and they would give us vasodilatation, but they are used in combination of low diuretics. The low diuretics are used for as the main or as the drug of choice for heart failure because they are very effective, and the thiazides used as a helping agent, so they would have more effect, and they work by decreasing volume and vasodilatation to relieve the heart failure. They also used in hypercalciuria, as I mentioned before, because they try to reabsorb the calcium and stimulate absorption kind of mechanism, and that would make the calcium in the filtrate would be reabsorbed here. The hypercalciuria, if not treated, it would give us low blood calcium and that would give us osteoporosis. So osteoporosis, and it also gives us kidney stones because the calcium goes into the kidney and it would lead to kidney stones, also known as nephrolithiasis. So nephrolithiasis. And the thiazides, as I mentioned, they reabsorb the calcium back, so they would be very effective for treating the hypercalciuria. They also used for the diabetes insipidus. Now, in diabetes insipidus, we have the ADH is decreased or is not even detected, and that's because either we have cranial diabetes insipidus, so cranial DI, where the ADH is not even released because of some pituitary issue from the posterior pituitary. And the other type is that the ADH is absorbed or is secreted. So let's make the other mechanism. The ADH is available, but we have the kidney is not responding to the ADH. So we would get nephrogenic DI. And the thiazides would not help us in the cranial type of diabetes insipidus. It would help us in the nephrogenic type, because the thiazides would make the kidney more sensitive to ADH, and it would give us a treatment to the diabetes insipidus nephrogenic type. So thiazides make kidney more sensitive to ADH. Now let's move to the adverse effects. So in the beginning of this lecture, in the mechanism of action, we talked about how the lipid or the thiazide diuretics would inhibit the Nacl transporter, and it would lead to the loss of 6 different things. That was 7% sodium, 7% water, potassium chloride, magnesium, so 2, 4, 5, and hydrogen. So if we lose one of these agents more than we should, it would lead to some abnormality. So if we lose a lot of sodium, we would get the hyponatremia. If we lose a lot of water, we might get the volume depletion. If we lose a lot of potassium, we would get the hypokalemic metabolic alkalosis. That's when we lose the hydrogen too. If we lose a lot of potassium, we get the potassium depletion here. And if we lose a lot of potassium and hydrogen, we'd get the hypokalemic metabolic alkalosis. And if we lose a lot of magnesium, we would get the hypomagnesemia. Yeah. We also might get hyperglycemia because the thiazide diuretics here is secreted from the proximal convoluted tubule here. So thiazides is secreted here, thiazides. We also have the uric acid here is also secreted from the proximal convoluted tubule. And if we give the thiazides to the patient, those would compete with the uric acid for the excretion here. And as a result of that, some of the uric acid would not be secreted and it would be trapped into the blood and it would give us the hyperuricemia, and that might exacerbate the gout or give us gouty attacks in people who are susceptible to this stuff. We might also have hypercalcemia because of the stimulate reabsorption of the calcium, because if we reabsorb a lot of calcium from the filtrate, we will get the hypercalcemia with these agents. So we also might get hyperglycemia and altered lipid metabolism because thiazides would lead to less potassium. So thiazides would give us less potassium, and the potassium is essential for the secretion of insulin. So if there is less potassium, we would get less insulin. So less insulin, and that would give us hyperglycemia. We also, because of the low potassium, we have the GLUT4, which is essential for the glucose to enter the cells, because it's a transporter that make the glucose, so glucose here goes into the cell by the GLUT transporters. And if the potassium is less, this would give us the GLUT4 is less efficient in making the glucose enter the cell, and that would make the glucose be trapped in the vessels and would give us hyperglycemia. And secondary to hyperglycemia, we would get the altered lipid metabolism, which is in form of hyperlipidemia. We also might get hypersensitivity reactions with the thiazides because their chemical structure is similar to the sulfonamides. And sulfonamides are very popular for their hypersensitivity reactions. We might get rash, or we might get some immune reactions like anemia, thrombocytopenia, which might get very dangerous. We might also get something very severe like Stevens-Johnson syndrome. Yeah. So that would complete our video about thiazides. Thank you guys for watching. Please make sure to like and subscribe. And the next video is going to be about potassium sparing diuretics. So stay tuned for that. Thank you for watching and see you in next time. Peace.